transition a little bit, you credited Dr. Mon for sort of leading the effort in creating sentinel lymph node biopsy, but you played an instrumental role in all of this. Can you just walk a patient through all that process, right? And then, you've been doing this since 1991, you spearheaded everything. Imagine, if I were a patient coming to you, right, and I had a melanoma breast cell thickness 1.2 millimeters and no ulceration, and I'm a young guy, let's say I'm coming to you. How do you start that consultation process?
Yeah, that's a great question. We kind of divide the conversation when we're talking to a patient about, listen, there are two things we need to talk about today. We need to talk about your primary melanoma, and we need to talk about your lymph nodes. And we do that with pretty much everybody, regardless of the risk. We understand a huge amount about the natural history, the biology, and the relationship between primary tumor characteristics and risk of spread to regional lymph nodes. But before I go into the conversation, I just want to say that Don Morton, he didn't invent this technique. This technique has been around since the dinosaurs wandered the earth, but he refined it and applied it to melanoma. And once he figured out how to make the technique work, and just as an aside, I remember flying out to California with a bunch of my colleagues and watching him do 6 or 8 of these cases and taking 2x2 Kodachrome slides and bringing it back and showing my tapes, like, we really got to do this. That was really fun, particularly when I was told by the nuclear medicine people that it couldn't be done. It was absolutely impossible. And then 3 years later, they were publishing abstracts in national meetings. I mean, they called that was a fun time. But what he demonstrated is that with this technique of lymph node mapping, that you could identify the regional lymph nodes in melanoma that melanoma cells would travel to if they were going to travel. And so, and then he went on in an extraordinary feat of academic honesty and transparency, is he tested the technique in a huge prospective randomized clinical trial where half the patients had a wide excision alone, and then if they recurred in the lymph node somewhere down the way, they'd have a lymph node dissection, and the other arm would, and that was sort of the standard at the time, and then everybody would have a sentinel lymph node biopsy, and then if they had a positive sentinel node, they'd have a lymph node dissection. What he showed was what every retrospective series had shown to date, is that the sentinel lymph node is incredibly important in determining whether or not the melanoma will come back after initial treatment. And
so I'm going to stop you for a second, because I think for our audience sake, because I mean, those are great history and like the background academic reason. What does that procedure involve? Can you comment, like, in terms of, we mentioned a little bit that involvement in nuclear medicine, and walk us through what is that process?
So from a practical standpoint.
Yeah, exactly.
Once we have thought a little bit, as we're talking to this patient, with this young man with his 1.2 millimeter melanoma, we'll talk to him about his risk of having tumor cells in the lymph node, which in this case is 10 or 15%. And because he's a young man, that gets his attention, and he wants to know. And because we've learned it's a prognostic thing, not necessarily part of treatment, we all think it's a good idea that this young man should know. Now comes the discussion about what's going to happen to you. And so what happens to this young man is he comes into the day surgery unit in the morning, and he has a test called a lymphoscintigram. That lymphoscintigram is the injection of a little bit of radioactive dye at the site of the primary melanoma. And very quickly, within minutes, this dye will migrate to the lymph nodes to which melanoma cells would go if they were going to go. It's really important to let those patients know that this doesn't mean that the melanoma has traveled. It just says if it's going to travel, these are the lymph nodes it's going to go. Okay. And once that's done, we get a visual picture called a map of where this particular melanoma would go if it were going to travel. It doesn't change that 10 or 15% probability for this young man, but it says if we're going to look at a lymph node, instead of doing what I used to do when I was just starting out, taking all of the lymph nodes out with all of the risks and complications of that procedure, we're just going to go take one or two out that are shown up on this map, this what's called lymphoscintigram. So we get that picture, and then once we've got the picture, we take this young man to the operating room, and we do two things. We do the wide excision, which we talked about as the first of the two things we do, and then we address the lymph node. And we use it's a remarkably simple technique, but we use a little focused Geiger counter, and we run it over the skin, and we can find an area of hot counts. It's kind of like finding like using a metal detector on the beach and finding your watch. You know, it's the Geiger counter shows us exactly where under the skin the lymph node is. We make a little incision there. We actually take the whole lymph node out because we don't know where inside that lymph node the melanoma cells might be hot if they were there. So we take that lymph node out, send it off to the pathologist, and they subject that lymph node to an extraordinarily rigorous pathologic analysis. It takes about 10 days to get that back. So it's not a quick turnaround. It's not a frozen section. On the day of surgery, and we've shown that the frozen section, that immediate during surgery pathology look, is not very accurate and not very helpful. So we take out the primary, take out the lymph node, the patient goes to recovery room. We tell the patient and their family everything went fine. We'll call you in a week or 10 days with some new information. And then we talk to them as soon as that report is back, and sort of take it from there. But so, it is, go ahead.
So just, I mean, this is great encapsulation and summary. So let's say, for instance, just to summarize for everyone. So let's say if your primary melanoma is on the left arm, and you do a wide excision, remove the melanoma on the left arm, and then you also basically go on to the left axilla area to identify the sentinel lymph node and remove that. Let's say the lesion is on the leg, then you're looking at the groin area, etc. What is the complication rate?
Well, I will say this: you are right, as in your description, 98% of the time. 2% of the time, we'll actually find lymph nodes in strange locations.
Exactly. Yeah.
So that mapping is incredibly important for that 2% of people. But then, you know, under the arm or in the groin area, you've got out of 10 or 20 lymph nodes. You don't want to be looking all through